Welcome to Riley Today, a video and accompanying web-based supplement produced by the Indiana University School of Medicine and presented by Riley Hospital for Children together with Clarion Health Partners. I'm Barbara Lewis, your host. This convenient source of current and accurate medical information is provided for busy physicians caring for Indiana's children. Each issue of Riley Today not only presents relevant information about the care of pediatric patients, but also offers a convenient way to earn continuing medical education credits, which we will discuss at the end of the program. On this edition of Riley Today, we explore 3 medical issues facing adolescents and their physicians. Before we get started, though, over the past year, Riley physicians and administrators have been traveling the state to hear what physicians in Indiana say they need in order to serve their patients even more effectively. Dan Fink, Chief Operating Officer for Riley Hospital, has a report of their findings.
Hello, I'm Dan Fink, Chief Operating Officer at Riley Hospital for Children. I've had the privilege of meeting many of you over the past year as I've traveled across the state with Riley physicians as part of what we call the Riley Listening Tour. We have visited practices in Muncie, Terre Haute, Columbus, Greensburg, and Richmond to hear what you have to say about Riley, to learn how we can better meet your needs and the needs of your patients and their families. Partnerships with community physicians are critical to our ability to effectively and compassionately care for children. Only through collaborative clinical relationships can we provide the best care available in a setting that is safe and comforting, and in a way that leaves patients and families feeling confident about the care they received. During these listening tours, we asked you what you thought, where we were strong, and where we need to improve. Today I want to continue that conversation, sharing what we heard and the changes we're making as a result. The insight you provided has been invaluable to all of us at Riley. We know it will help us to better serve you and ultimately your patients. First, we received overwhelmingly positive feedback about IMAC's OneCall, Clarion's physician call center. You told us that it really differentiates Riley's care. You were also pleased with our telemedicine program and transport services. And many clinical areas received high marks from you as well, including hematology oncology, developmental pediatrics, and pediatric surgery. You also shared some points of frustration with us, specifically communication and access. Our communication can be inconsistent and sometimes too slow. One physician commented to me, "I like to know who I'm sending my patient to." Understandably, you want ready access to those you've entrusted with your patient's care. In terms of access, patients aren't always seeing Riley specialists as quickly as you believe necessary, and some of you requested more local clinics. We've been evaluating these concerns and have already made important improvements. One of the most visible ways we're improving our communication is in the admitting process. Previously, admission notifications weren't always quick or accurate enough. Today, our staff is required to let referring physicians know within 1 day of a patient's inpatient admission. We're also working to improve written discharge communication, adding more clarity around what the Riley subspecialist has ordered. We're also improving communication by adding hospitalists to our staff this summer. We believe these physicians, whose primary role is to oversee aspects of a patient's care during the hospital stay, will aid communication regarding patient care. Look for more information about hospitalists in our quarterly newsletter, Riley Physician Update. We're also addressing the important issue of access. We're adding more telemedicine clinics to meet that need. As an example, Riley's developmental pediatrics was one of those clinical areas that experienced extremely high volume, making it challenging to see patients as quickly as we'd like. Earlier this year, we launched a telemedicine clinic for developmental pediatrics with Memorial Hospital of South Bend. Already it has hastened the patient follow-up process. We'll continue to look at clinical areas and pockets of the state where we can put additional telemedicine programs. We're also working with several clinical areas to improve scheduling. Many of you shared that you'd seen vast improvements in gastroenterology, and ophthalmology, two service lines that have been challenged by this issue. We think you'll continue to see improvements in other areas as well. Finally, several of you asked about scheduling services and placing pharmacy orders online, and you also requested more patient education. We're investigating these areas and how we can address your requests. Our desire is to better serve you. If you have any questions or further suggestions, feel free to contact me personally. Thank you for your time.
Riley Hospital offers a vast spectrum of specialists and subspecialists to help treat young patients. Among those specialists are those who focus on the needs of adolescents. Today's edition of Riley Today focuses on 3 medical issues primarily related to this group: eating disorders, polycystic ovarian syndrome, PCOS, and the new HPV vaccine. Eating disorders are a growing concern in today's youth population. Popular television programs, movies, and magazines send a clear, though untrue message that you have to be thin to be happy, successful, and desirable. In the United States, more than half of teenage girls and 1/3 of teenage boys use unhealthy weight control behaviors, such as skipping meals, fasting, smoking cigarettes, vomiting, and taking laxatives to keep their weight down. In this segment, Dr. Mary Rouse, Associate Professor in Clinical Pediatrics and Medical Director of the Caras Center for Eating Disorders, discusses the diagnosis and treatment of eating disorders. At the conclusion of Dr. Rouse's segment, we should be able to identify patients with weight concerns and unhealthy responses to their weight, assess for medical complications related to eating disorders, and describe medical monitoring and treatment options.
Anorexia nervosa, bulimia nervosa, and related eating disorders are unfortunately becoming very commonplace in today's society. The modern press has glamorized the illness so much that young kids are quite aware of it. In the U.S., the Diagnostic and Statistical Manual of the American Psychiatric Association sets the criteria for eating disorders. Over the last several years, these criteria have been scrutinized and actually are undergoing revision for the next DSM. It is particularly problematic for children because their height-weight ratio often does not vary and does not fit the criteria for an eating disorder. But the criteria as we have them now for anorexia include refusal to maintain weight at or above 85% weight for height for age, fear of gaining weight, and this includes fear of body fat and eaten fat, body image distortion, which is actually the hallmark of anorexia, and this is thinking you are morbidly obese when you are actually quite emaciated, and then amenorrhea, which is no menstrual period for 3 months after having established period. Anorexic patients will have periods of binges and purges, but their main mode of coping and using their eating disorder is by restriction. For bulimia, one must binge, which is eating a larger than normal amount of food in a particular period of time. In our current low-fat society, the binges are much lower cal than they had been in years past. It was not atypical to have a binge of 10,000 calories. Now the binges are closer to 1,500 or 2,000 calories, but the quantity is large. There is then compensatory behaviors such as vomiting, laxative use, diuretics, and rarely bleeding as a way of weight control. There is not the body image distortion that there is for anorexia. However, their self-evaluation is unduly influenced by their body shape and weight. These behaviors must occur twice a week for 3 months. The largest category with the most controversy as far as criteria is eating disorder not otherwise specified. These are basically the folks that fall between the cracks. These are the girls who have periods because their primary care provider has put them on oral contraceptives, and so their amenorrhea is masked. Often the binge purge frequency is not that which is required. And then there is binge eating disorder, which is a good part of the eating disorder not otherwise specified category. With the next DSM, it will come out with its own criteria, and it is basically bulimia without the purging. Parents' first question is often what caused this eating disorder. Unfortunately, there's no real good answer to that. We know that it is multifactorial, having biological, psychological, and social aspects to it. The most commonly described model is that which characterizes an eating disorder patient as having genetic predisposition, as shown by increased incidence of depression and anxiety in a patient's family. The psychological characteristics of perfectionism, people-pleasing, poor self-esteem, and fear of growing up add fuel to the fire. Our current fat-phobic society provides a vehicle for these patients to deal with their fears. Simply said, genes load the gun, environment pulls the trigger. Most of the research money right now is on the biology and genetics of this disorder. Unfortunately, even though the disorder is so pervasive in our society, there is very little research money to support some of the efforts that are being done around the country to look at the etiology of this. Patients often come to the office and claim that they have no particular problems, they feel fine, they have lots of energy, despite the fact that you know that they are not doing well with their illness. There are quite a few complications that happen in eating disorders. Electrolyte abnormalities happen most commonly in bulimic patients. They suffer from hypokalemia, which of course can cause cardiac arrhythmias. There also is a problem with hypophosphatemia with patients who refeed, particularly those who are very malnourished. This should be watched very closely so as not to cause cardiac complications during the refeeding process. Cardiac complications are fairly numerous. Along with the arrhythmia that occurs with hypokalemia, there's usually a significant bradycardia. Adolescents should probably never have a heart rate below 50. They often will say that they are athletic, but they do not have athletic hearts, they have anorexic hearts. Adolescents with heart rates below 50 should probably be restricted from sports and other aerobic activities. Patients with heart rates below 40 should be considered for hospitalization. They should then be refed and not discharged until their heart rate is above 50 consistently. Gastrointestinal complications include esophagitis from the vomiting, Mallory-Weiss tears, which is a common reason to come to the emergency room, and then superior mesenteric artery syndrome. This happens with a rapid weight loss, and it should be considered in an anorexic patient who has a rapid weight loss who denies that the vomiting that is occurring is self-induced. Interruption of major endocrine axes can also cause problems. The hypothalamic pituitary gonadotropin axis is very often affected, causing amenorrhea and then resultant osteoporosis.